Hello and welcome. We will get started momentarily. As you're logging in and getting connected to audio, please feel free to use our chat feature. We would love for you to put in your name and organization just to see who's tuning in today. And then throughout the session, if you want to use the chat to add additional comments to share with the group or questions for me, please feel free to use the chat feature throughout. We should have plenty of the time to address questions today. We'll get started in just a moment. Hello, Lisa and Donna, Jacqueline, nice to see you today. Okay, we'll go ahead and go to the next slide. We're right on the hour here. Today's Nursing Home Quality Essential Spotlight on Infection Prevention is on the COVID-19 vaccines for fall and spring and why boosters are already approved. My name is Megan Myers, and I'm the clinical pharmacy specialist and also the pharmacist for Telegen. Next slide. If you were forwarded this invite and have not registered for our series, there's a QR code there to register. We have weekly sessions on Tuesdays and Thursdays. Next slide. And then we also have this email, QI@telegen.com. So make sure that's on your trusted list of email contacts as well, because that is how we send out resources and information on events like this one. Next slide, please. Oh, and welcome everyone. Thank you for joining us in chat too. Today's topic, our objective is to discuss the guideline recommendations for the 23-24 COVID vaccine, which was just updated at an ACIP meeting last month in October. We'll describe the rationale to support spring booster approval for adults 65 and older, and for those with moderate to severe immune compromise. We'll discuss challenges to providing vaccine services, and then identify some resources to help support your practice. Next slide. Okay, as we get into our COVID-19 vaccine updates, we will also have some polling questions. So I just wanted to put this as a little pause. We'll be using a feature called Mentimeter, and if you have a smartphone, take a minute to get that out, and you'll be able to scan a QR code, or you can open up another window in your browser to participate. And if it's easier to put your answers in chat, that works just fine too. We're really just using this feature to hope to learn from you as well today so that we can better support you. Next slide, please. Okay, so now here's the slide for Menti. So if you do have your phone out, you can scan the QR code. And if you are using the browser, you can go to www.menti.com and then enter the code 3386609. And I'll just give you a moment to do that. That's great. I'm seeing a lot of thumbs ups on the Menti, means you're getting it in okay, and that's wonderful. Okay, we'll go ahead and go on to the next slide as you're logging in. So we're curious, have your residents received their fall 2024-2025 COVID vaccine that was approved and became available in September? So just a yes or a no. This is anonymous on the poll, so we won't know who put in what answers, but we definitely have seen rates are lower right now than they were this time last year. So we know that there have been some challenges at some of the facilities. Oh, this is great to see so many of you on top of it. Great job there. I know that that is not an easy task, so congratulations on achieving dose 1 for the year. Okay, we can go ahead and go on to the next slide. And so for our meeting in October, the new recommendation, it's actually the same as last year in terms of 2 doses. So 2 total doses of the 24-25 COVID vaccine is recommended, ideally 6 months apart, for everyone 65 years of age and older. So that 6-month interval is something that has been established at this last meeting, but they also established a minimal interval of 2 months. So basically the second dose could be given anytime between 2 and 6 months after the first dose, which hopefully gives some more flexibility for mass clinic efforts or mass immunization efforts. And then if they're over the 6 months, they're just overdue. They could still get the dose if it's been more than 6 months. And then there is just one exception, and it will probably not apply to very many people, but if somebody is previously unvaccinated and they're getting Novavax, then they would do a 2-dose initial series followed by a booster. And then the recommendation for moderate or severe immune compromised patients is very similar. So if they're previously unvaccinated, they do recommend a multi-dose initial series and then a booster. But for those previously vaccinated, which most of them will be, again, 2 doses, ideally 6 months apart. But then there's an additional caveat that they may receive even more doses under shared clinical decision-making. So if you have somebody that is immune compromised and really prone to like reinfections or higher risk, then they could get additional doses based on the discretion of their medical provider. So that's something to keep in mind, since many of our patients over the age of 65 also qualify for those immune compromised conditions. I'll also note that there was discussion on pneumococcal vaccines and RSV at this October meeting as well, and I'll be doing a session next month on the pneumococcal updates. And then the RSV, they discussed everything, but they affirmed the current guidelines from June, so there's no changes there. And currently it is still just that 1 dose protection, and they know from the current data that that's going to cover for at least 3 years. So right now there's no boosters recommended. That may change in the future, but if somebody's received RSV, they're good to go for this season. And then Andrea, you had a great question. If it was in mid-October, yes, so then it would be 6 months. So they would get that 6-month period before it would not be up to date. So that would be correct. Great question. And then next slide, please. Okay, and this is your second one. So we just have 2 polling questions in today's session. What are some of your challenges in keeping your residents up to date for the COVID-19 vaccine? And you can mark all that apply. These are just some of the things that we've heard from nursing home partners. So keeping up with the guidelines, residents, getting tired of getting doses, that vaccine fatigue, caregivers, that vaccine hesitancy, whether they're against the vaccine for personal beliefs or that they've had bad experiences with the side effects in the past from past vaccines. We know staffing shortages can be a limitation when it's time intensive to identify those patients, get consents, administer, document, bill, manage inventory. You have a lot of competing priorities, and sometimes that's a challenge. Vaccine supply, now we have not heard this being an issue this year. We've seen it in the past, so I wanted to put it on there in case there's something we're not aware of. And then billing and reimbursement. And if you did notate other, I would love more detail in the chat or email us so that we can continue to kind of be in the know and work on providing resources for you. And I'm not surprised that I've seen a lot of you have marked the first 3. And I think in part that could all be interrelated. There were a lot of challenges while we were reacting to a new worldwide pathogen in real time. And it was exhausting to keep up with it all. And our messaging and our education to patients also continued to change throughout, which I think instilled frustrations and doubt from that patient perspective. So I'm not really surprised to see some of those getting marked. Next slide, please. And I'm not going to lie, when I saw another guideline change, I did an audible sigh. I'm just like, oh boy, here we go again. But as I listened to this ACIP meeting and the data being presented, it felt like a light of standardization at the end of a very, very, very long tunnel. These intervals, the intervals have varied throughout the pandemic, and now we have intervals that align with other vaccines. And just that small bit of standardization makes me hopeful that this is it. Next, we'll move into the rationalization for this recommendation. So we can go to the next slide, please. These next several slides have graphs, pictures, and information from the October 2020 2024 ACIP meeting that was presented by Lauren Roper, MPH, under the presentation, The Evidence to Recommendations Framework. And I have a link in the slides here to that PDF and also to the YouTube video of the meeting. Her presentation is around the 5-hour, 50-minute mark. So if you're interested, it was a very well done presentation. If you're like, this is great, but I want more information. And these slides will go out after today's session as well. So first, while COVID-19 circulates year-round, it consistently has peaked in the winter and late summer every year since 2020. So we actually do have established COVID-19, what you might call seasons. Like, yes, it circulates year-round, but we do have established peaks. Next slide, please. And then the hospitalizations have aligned with these peaks as well. So with the peaks being in winter and late summer, the ideal, like, quote unquote, time to get vaccinated would be before these peaks. So we would get vaccinated in the fall before the winter peak, and then spring and early summer to cover that late summer peak. Next slide, please. So you may be wondering, if there are 2 annual peaks, then why is the spring dose only recommended for 65 and older and those with immunocompromised? Like, shouldn't it be recommended for everyone? And of course, now we all understand, the virus mutates, the formula needs to be updated, similar to the influenza vaccine. But then there are some additional unique challenges to keeping older patients and those that are immune compromised protected from COVID-19. Next slide, please. So first, this is directly again from the CDC's presentation. The first thing is that they have not developed a robust immune response to the COVID-19 virus or vaccine. So it is important to regularly boost the immune response with vaccination, and it has a part to do with how our immune system responds to new pathogens. So when we're born, we have a pool of naive T cells with our immune system, and it is the naive T cells that are required to develop that initial immune response to a new pathogen. And those pools of T cells diminishes with age. So when we're older and we're exposed to a brand new pathogen, we don't have as many naive T cells to develop that initial immune response, and that goes down the line to just having a less robust immune response to begin with. And so kids and people who were younger when this new pathogen came out, they developed a more robust immune response than somebody who was older. And then immunocompromised conditions, they directly suppress the immune response, which is a different mechanism than what we just discussed, but the end result or outcome is similar. Next slide, please. And then partly because that immune response, immunity from either vaccination or previous infection, it wanes faster, which puts them at higher risk for infection or reinfection. And then the data here is from the 2023-2024 COVID vaccine, specifically in adults 65 and older, but the data is similar in people with moderate to severe immune compromise. And the immunity is impacted differently for different outcomes. So for the first bullet point, it says protection waned to essentially 0 6 months post-vaccine for the outcomes of COVID-19 related emergency department, urgent care, and hospitalizations. It still remained effective against the most critical illness and death, but against some of those other outcomes, it essentially had no protection by 6 months out. And then the additional dose did boost that additional protection. It was effective in keeping them protected against those outcomes. And these results are similar to all the previous COVID-19 vaccine formulations, so this has been consistent throughout the pandemic. Next slide, please. And then when someone is infected, we have some more serious outcomes for COVID-19. So 70% of all hospitalizations related to COVID-19 infection were in patients aged 65 and older, and it was even higher chance if they were 75 and older, which accounted for half of all hospitalizations. And then 1 in 6 people hospitalized had an immunocompromised condition. And then those patients were at increased risk for an ICU admission or for being on ventilation. The top immunocompromised conditions amongst the hospitalized patients were taking therapy or medications that suppress the immune system, which included steroid therapy, cancer, and then solid organ transplants. Next slide, please. And then COVID-19 does remain the leading cause of viral respiratory deaths in the United States. So in this graph, the orange bar is deaths from COVID-19, the blue is deaths from influenza, and then the purple, which is barely visible, are deaths associated with RSV. And vaccination does remain the best strategy we have to reduce the risk of these severe outcomes. Next slide, please. So now we have a sense of the seasonality of COVID-19 and an understanding of why our seniors need that second dose that the younger adults really don't need unless they are immunocompromised. Our seniors are at higher risk of more severe outcomes from COVID-19 infection, and their immunity from vaccination or infection wanes faster than the younger adults. So meaning like 1 dose in the fall isn't enough to cover both the winter and late summer peaks for those that are 65 and older or immune compromised. And then another unique note is that among our population, we have immunity from vaccine, immunity from infection only, or combo immunity from both infection and vaccination. And those aged 65 and older have the highest proportion of vaccine-only immunity. So it's a really important strategy for this population. But how do we overcome the hesitancy that has come with living through, and reacting to a new pandemic level pathogen with all the pivots and turns that came along the way? Personally, the data I've shared with you, it does give me some hope that we have a better understanding of COVID than we did even a year ago, and definitely, compared to 3 or 4 years ago. So hopefully we can start working on some messaging based on this and be confident in that messaging. So I encourage and I challenge you to get a consensus among your leadership and team on what messaging you want to relate to your residents and their caregivers. Because we've done a lot of messaging that has had to change based on what we knew at the time. And of course, there's a lot of messaging out there that have really capitalized on that downside of reacting to a new virus in real time. We know that there's a lot of information out there, and not all of it's good or accurate, or some of it hasn't been updated. And perhaps some of them just are exaggerating the negative. So we can take this information and hopefully be empowered to combat some of that messaging. You're trusted. You're in a position to provide a strong vaccine recommendation that can impact the health and safety of your residents, and consistency is key. So developing a message that your staff can rely on and repeat can have a big impact. And I think, I have compassion for Denise's comment, like someone said they would get it if it was an annual vaccine. And we know that sometimes patient care involves negotiations. So kind of looking at this data and knowing the winter peak is the worst one, maybe that's where you say, okay, if you're just going to get 1 dose, let's try to get you the best protection we can. This is when I'd recommend you get it. As well as that education on why a second dose is recommended for that age group. It's hard out there, and I know that it's not easy. So I commend you for going out there and doing the work. Next slide, please. So out of all the challenges, we've tried to develop some resources to support your work, maybe do a little bit of that fact-finding legwork for you. And in the remaining time, we'll go through some of the resources we have available to help you with keeping up with guidelines and just going through some of these issues we've discussed. And the one we have right now on that screen is one of my favorite flyers that we developed based on barriers our nursing home partners have told us, where we have the barrier that residents commonly express, or even our staff, and some factual information, quick snippets that you can use to build your messaging around. Next slide, please. And then we have a couple of different resources I'll highlight today. I know that there are so many resources available, like hundreds of pages, and sometimes it can be challenging to find what you need when you need it. Intelligent responded by developing an online toolkit that's basically a compilation of the best resources out there. It's available at no cost, and we work to maintain it to ensure that the information is in there is up to date. The intention is to provide resources from the organizational level down to the provider level. And so we'll go through some of the key items in that toolkit. And then we have some items in our learning management system, which again is trainings at no cost. And a couple of those are really good for vaccine efforts as well. Next slide, please. Okay. So for accurate clinical and billing information, we have those in the adult vaccine toolkit. In a couple of my favorite sections. So Why Get Vaccinated has some of those like IP facts about infection and efficacy of the vaccine. So those fact finders you can find good information there. We have some patient care considerations for individual patient needs, as well as vaccine specific resources. So we do have within the vaccine specific resources, we have a flyer for patient education on COVID that compiles, again, accurate information on this year's formulation. And then we do have some CMS billing guides and other helpful resources in the billing management section as well. Next slide, please. And then for vaccine hesitancy and fatigue, we have, again, that Why Get Vaccinated for the fact finding, but we also do have some specific resources on vaccine hesitancy, both within its own unique section, but also vaccine specific resources. And then we just launched a motivational interviewing for healthcare providers module that's just 30 minutes, and it was really well done. And I think that might give you an idea of ideas to spark messaging, again, for your staff to relate to patients. Next slide, please. And then we know that documentation is a burden, and navigating the NHSN is not always simple, especially if you're new to your role. And we have a lot of resources available around this, and including sessions built into this series where you can come on and ask questions. So I have links to our NHSN resources. We also have experts on our team that are really good at navigating that. So just know we have support around that. And then the short staff, this is the big one. I know that sometimes just the amount of work to do and what you have, like realistically, sometimes you just need someone to come in and take a burden off your shoulders. You need a vaccine clinic partner. And so what we've been working on at Telegen is going out and finding the groups that will go offsite and provide vaccine clinic services. So we have a list, a lot of them have pharmacies. We have some options with public health departments when we're aware of those opportunities. And we've compiled those lists for our team to support you with. And so if you're like, I just need a vaccine clinic partner, you can email nursing-home@telegen.com, and we would be happy to check if we have partners identified near you, and we can give you their contact information to reach out and see if they're available to help support you. And I'm continually making calls and trying to build up this list. So hopefully my goal is I would love to be able to have a name to give every nursing home in our state, in all 4 of our states. That's my hope and dream. And so even if you email us now and we don't have anyone, try back again in a few months, because I'm continuing to work to build this list. Next slide, please. And then you're in the thick of it right now, so this is probably not the time to establish or improve a vaccine program. I understand how fall goes. I ran vaccine clinics during COVID, so I understand that rush and that busyness. But I did want you to be aware that we have quite a few resources for establishing or improving upon a vaccine program, including a CE accredited immunization escape room on our learning management system. So that's great if you're new to your role and want to try to build or approve a vaccine program. We also have resources built into our adult vaccine toolkit and our quality improvement workbook. So those are all great resources to look at if you're trying to, figure out where to start with that. Next slide, please. So today for our leave in action, we have a lot of challenges, and you can't fix it all in one go, but it's just assessing, what are your most pressing challenges to vaccine uptake at your facility? What one change could make the biggest impact? And just going after that challenge. I challenge you to develop some COVID-19 messaging for this season and making sure that the staff has that consistent messaging so that you can be confident that everyone knows how to answer the questions or knows who to talk to or refer to within the facility. And then looking at the tools and resources we have available, because hopefully they're helpful to you. And we're always open if there's you're like, I need this, just reach out to us, because we're constantly trying to build resources tailored to support your efforts. So this is what we have. So we can go to the next slide and just check in if there's any questions. You're welcome to chat questions, or if you want to come off mute, because it'd be easier just to say your question, just go ahead and come off mute, and we're happy to answer any questions you have. And then we can go ahead and go to the next slide. We do have a general inquiries email. If you'd like to reach out to us, it's QIConnect@Telegen.com, or you can use the nursing-home@Telegen.com. That works too. Next slide. And then here are our sessions upcoming for the next couple sessions here. So take a look, and hopefully you can join us for those sessions as well. Next slide. So we thank you for participating. Once this session does end, there will be a post-event survey. It'll pop up in your browser, and we really take the feedback seriously. We value it. So please take a moment to share your thoughts with us. And thank you for participating in this session. Have a great rest of your week. Oh, there's a great question. To be classified up to date, do they have to have 2 boosters in 24-25? So that's great. So if you have already given the residents their fall dose, then they'll need 1 more dose, ideally in 6 months. And so 2 doses total for the year to be up to date.
Have you heard any different requirements for isolation for nursing home resident recommendations?
Yeah, that's a great question. I have not seen any changes come across, but I'll double check with our infection preventionist as well to see if he's aware of anything. But I haven't seen it, so I'll double check with him though.
I know that meeting was the 14th and 15th. Is it PAC, or I don't remember the exact name of the group. And I didn't hear the meeting, but I heard public comments being made by people with their opinions on things on the isolation time. So I didn't know how long they take to decide what their recommendations to CDC or whatever will be.
Yeah, no, that's a great question. I will check with our infection preventionist and see if I can find anything on that, because I know sometimes it takes a while once a decision's been made for all the materials to get updated. So there might just be a lag time in that. Yeah, thank you for asking that. That's a great question. Hey, do we have any other questions today? Okay, well, thank you very much. Thank you for joining, and hopefully we'll see you next time.